안녕하십니까. 오후에 다시 공부를 시작을 하겠습니다. 여러분 책자에서 이미 다 알고 계시겠지만 이번 세션은 스트래텍틱 앤 펑셔널 뉴로서저리 분야 중에서 딥 브레인 스티뮬레이션에 대해서 이렇게 주로 강의를 하겠습니다. 두 분의 저명하신 외국 분들을 모셨거든요. 첫 번째 선생님은 일본서 오신 가타야마 선생이시고, 두 번째 연자분은 미국에서 오신 알트만 선생님이십니다. 먼저 가타야마 선생님의 강의를 듣도록 하겠는데요. 가타야마 선생에 대한 양력은 여러분들 가지고 계신 매뉴얼에 있습니다. 그래서 지금 현재 일본 대학의 신경외과 주임 교수로 계시고, 또 외국에서도 많이 공부를 하시고, 또 지금 주로 스트래텍 앤 펑셔널 그리고 뉴로 트라우마톨로지에 관해서 많은 업적을 가지고 계시고, 또 여러 관련 잡지의 편집장 혹은 편집위원으로 활동을 하고 계십니다. 그래서 오늘 가타야마 선생님이 말씀해 주실 내용은 Feed Forward Control of Involuntary Movements by Cortical and Deep Brain Stimulation에 대해서 말씀을 해주시겠습니다. 가타야마, please.
Thank you, Professor Kim. Good afternoon, ladies and gentlemen. I would like to express my sincere thanks to Professor Hee Won-jun for giving me this opportunity. It's a great honor and pleasure to visit Seoul National University. This is a DBS system. Intracerebrally implanted electrodes and implantable pulse generator. In 1979, which is 26 years ago, we performed the first DBS surgery in Japan, which was DBS for pain control. In 1988, we performed the first DBS surgery for movement disorders. Therefore, it took us more than 10 years to obtain government approval for each procedure. But immediately after the approval for movement disorders, many medical centers in our country started to perform DBS surgery. Since 1979, we have investigated DBS of various brain areas for pain and movement disorders for many years. For example, 10 years for globus pallidus and 8 years for subthalamic nucleus. We experienced a variety of movement disorders with DBS in more than 200 patients until 2002. The number may be more than 400 now if we include DBS for pain and those we performed during recent years. The numbers are rapidly increasing during these 2 years. This is just an example. Generalized dystonia. We perform pallidal stimulation, bilateral. This patient is one we experienced 5 years ago. Before surgery, the patient shows this type of camptochromia-like bending of the trunk. Little symptoms in appendicular structures, but neck and spine are deformed. This is after surgery. Bilateral stimulation of pallidum produces excellent effect. We have experienced now more than 30 patients with dystonia, and approximately 70% of them responded well to the stimulation of globus pallidus. That means this effect is not always obtainable in the patient group with dystonia. We investigated various aspects of DBS for movement disorders. I would not get into the details of this report today, but I wish to point out one problem which we encountered in our country in popularizing DBS, especially for Parkinson's disease. In our series of Parkinson's disease, 72% were referred to us from neurologists, and only 23% from general practitioners. So there is no question about the important role of neurologists here for popularizing DBS. This is not a problem. Neurologists are happy to see the patients after DBS surgery. In our series, neurologists continued to observe 93% of patients after DBS. So they are very much interested in observing the effect of DBS after surgery. But there is a problem. Medication and tuning of the DBS system are both performed by neurologists in only 16% of patients. In the remaining patients, tuning of the DBS system was performed by us neurosurgeons. Neurologists continue to give medications by themselves in 49%, but they don't want to do tuning of the DBS system. In the remaining 36%, neurosurgeons are even asked to perform both tuning of the DBS system as well as medications. This is a big problem because we become responsible for more and more patients as we continue to operate new patients every week. We become busy more and more for just following up the patients. We are a specialist of surgery. Our responsibility is to perform best surgery. We need to ask neurologists to help us to tune the DBS system and modify medications at the same time. This is practically most important to maximize the benefit of patients. But in our country, recruitment of neurologists who are enthusiastic in both patient selection and tuning the DBS system after surgery is not easy. We are now in the process of struggling to establish the this type of medical system. Next, I move to the topic which I am currently working on. Since Dr. Alterman from United States will make a broad spectrum review for the advantages of employing DBS and the characteristic of this technique, I wish to concentrate on just two aspects of DBS in my lecture, which I believe very important for future development of DBS. One is a spatial controllability of DBS. In thalamotomy or pallidotomy, we need to identify the most effective target, which should be minimal as much as possible. You cannot make a big lesion in the brain. In contrast, we can distribute and arrange DBS contacts in wide areas if necessary. The DBS electrodes have 4 contacts, so we can arrange these 4 contacts in the wide brain area if necessary. The other is a temporal controllability of DBS. We can switch on and off the DBS system, which will enable us to trigger the DBS system only when stimulation is needed. This advantage will open up the possibility of controlling the DBS system by intrinsic signals, which can be detected from the body or even the brain. First, I would like to show you my experience for the spatial controllability, which was very advantageous in particular groups of patients. During DBS surgery for tremor, cell activity with the same frequency as tremor is recorded. These cells are named tremor cells. Tremor cells show varying degree of grouping discharges. This is a tremor cell. Show only a little grouping, but the frequency is the same as tremor EMG. This is different cell. You may be able to hear the rhythmic discharges. This is another cell with clear rhythmic discharges. These tremor cells are important sign indicating the appropriate location for stimulation. Because of such variability of the degree of grouping, we need to analyze cell activity as well as tremor activity by spectral analysis. In this case, frequency of cell activity and tremor activity of agonist and antagonist muscles are exactly the same. We confirm coherence of cell activity and tremor activity. If coherence is greater than 0.4, we consider this cell is a tremor cell. This procedure is very important because some cells show rhythmic activities, but the frequency is not the same as tremor. We plot such cells on atlas. Here, the border between the sensory nucleus and ventralis intermedius nucleus. This is a target of tremor surgery. And when we get into this area, we see many tremor cells. But tremor cells are not located only in ventralis intermedius, but also in ventralis oralis. In other words, this is a lateral view. The PC is a posterior commissure, and this is millimeter. It is clear these cells are distributed widely from the nucleus ventralis intermedius to the nucleus ventralis oralis. This is a summary of 307 cells, tremor cells are found in the nucleus ventralis intermedius as well as ventralis oralis. There's almost the same incidence of the tremor cells among the all cells we recorded. Almost the same. Especially in essential tremor, the tremor cells are located more frequently in ventralis oralis. But the classic thalamotomy, the target is in the ventralis intermedius. In DBS surgery, we can arrange the DBS contacts in such a way that both of these nuclei can be stimulated. So there is a possibility that we need to stimulate not only ventralis intermedius but ventralis oralis. Based on these findings, we need to think about that possibility. Our experience says that the Parkinsonian tremor can be very well treated by the thalamotomy located in ventralis intermedius. But in essential tremor, we sometimes need to extend the lesion from the ventralis intermedius to ventralis oralis, which means larger lesions. In the case of DBS surgery, we can just arrange the DBS contacts to cover both of these structures. As you can see, if we place the DBS electrode or DBS lead at a low frontal angle here, like 45 degree, 4 contacts, 1, 2, 3, 4, of DBS lead can be arranged within both the nucleus ventralis intermedius and ventralis oralis. If you approach, as written in the textbook, at a high frontal angle, something like 60 degree, you will place 4 contacts only within the ventralis intermedius. That cannot maximize the advantage of DBS therapy because you can arrange the 4 contacts to cover both the ventralis intermedius and ventralis oralis. To my experience, this is very important for some patients, especially those with essential tremor or post-stroke tremor. This is a photo. 2 X-ray films taken twice during the surgery are superimposed. The placement at high frontal angle here, about 60 degree, which place all the 4 contacts within the nucleus ventralis intermedius, and we observed a very little effect on tremor. The effect is actually unsatisfactory. So we reintroduced the electrode, making a burr hole in the frontal area, and introduced the DBS lead at low frontal angle, like 45 degree. The 4 contacts are now placed in the ventralis intermedius, but also the ventralis oralis. In this placement, the tremor was excellently controlled. The tremor is immediately stopped, even after just inserting the electrode. This type of experience was more frequently encountered in patients with essential tremor or post-stroke tremor, but you will experience similar phenomenon in patients with Parkinson's disease also. In some patients with essential tremor or post-stroke tremor, we need to employ dual lead DBS to control tremor completely. This arrangement of DBS contacts cover the entire area of the nucleus ventralis intermedius and ventralis oralis. This side is frontal, and the electrode is inserted from the frontal warhol, lateral view. This is the X-ray film showing placement of dual lead DBS. This type of modifying large extent of thalamic structure is not possible by thalamotomy because the lesion is too large. And we don't need to make such a large lesion in the case of DBS. We can just arrange the electrode contacts to cover this area. In this patient, DBS with lead 1 attenuated tremor. This is off stimulation. This type of tremor can be controlled. This is off stimulation. He cannot write any character. When you on the lead 1, no tremor at this time for finger test. But when he tried to write, tremor occurs, so he cannot write at all. When you use lead 2, again, tremor is very well controlled. But when he tried to write, tremor occurs. When you stimulate with lead 1 and lead 2, he can write very clearly. This is an advantage of DBS, which can be called spatial controllability of arrangements of DBS contacts. Now I move to the other advantage of DBS, that is temporal controllability. The temporal controllability enables feed-forward or feedback control of DBS using intrinsic signals which can be detected from the body or the brain. This concept was briefly described long ago by Bryce and McLellan as a contingent DBS, which means DBS is switched on automatically only when it is required. But no further development was made since then. In cases of posterior tremor, tremor mechanism is activated by posture. The posture activates tremor mechanism. Therefore, signals related to posturing can be used for feed-forward control of tremor. On the other hand, signals related to tremor can be used for feedback control. I would like to show you preliminary attempts of feed-forward control of tremor. This is a patient with posterior tremor. No tremor at rest, but when he does finger test, the tremor occurs. Before internalization of DBS system in this patient, we were given the opportunity to test whether the feed-forward control is possible or not. And we recorded EMG activity from the deltoid muscle, which is activated when he raises his hand. The deltoid muscle activated, and then tremor happens, tremor occurs. So we tried to use this deltoid muscle activity as a trigger of DBS system on, a very severe tremor. When he stopped, raise his hand, no tremor, tremor disappear. Once again, raising his hand, deltoid muscle activities, and then a tremor occurs. So now we trigger the DBS system by the activity of deltoid muscles. The activation of DBS system is displayed here. You can see a red line here when the DBS system is on. Now the feed-forward system is activated. He raises hand, DBS system become on, no tremor this time. This means the feed-forward control of intention tremor is successful. He stopped raising hand, and again he raises his hand, the stimulation on, and no tremor. When he stopped raising hand, the activity disappear and the stimulation system become off. This is a patient after internalization of DBS system, which is switched on. No tremor is induced by raising his hand. Feedback control of DBS is currently unsuccessful. Here, the feedback control is a control triggered by tremor, because the tremor is a signal for activation of DBS system here, so that when tremor becomes very strong, the DBS system is activated. Because DBS is activated, the tremor is suppressed. So the DBS system switched off. Then the tremor reappear and the DBS system reactivated. And because of DBS system, the tremor attenuated. Tremor attenuated, then the DBS system switched off. So this cycle is a problem. That is the reason that feedback control of DBS is currently unsuccessful. Then this oscillation like on and off are repeated as far as tremor continues. So this totally confuses feedback control system. This is an example. This is off stimulation. And when the DBS system is switched on or off, you can see PIP. The PIP is the signal that the DBS system is switched on or off. Because this is DBS system is off, you cannot see any PIP. But now the feed-forward control. Did you hear PIP? This second PIP, the DBS system on. Oh. Tremor is greatly attenuated, although the tremor of contralateral side is remaining. Now feedback control is like this. Many PIPs, the DBS systems are on and off, like oscillatory oscillation. The amplitude of tremor shows fluctuation. This is why I'm saying that feedback control is currently unsuccessful. In contrast, the feed-forward control of DBS is possible using intrinsic signals detected from the body. Then it may be possible to use intrinsic signals from the brain. For example, near-infrared spectroscopy, you can see the activation of the hand area. This indicates that the intense intention tremor is happening in the other side. This signifies that intrinsic signals of related to the tremor. So using this signal is now theoretical one, but in future we will have many different modalities of signals which can be detected non-invasively from the brain, and some of them may provide us the opportunity to switch on and off the DBS system. In this type of feedback control or feed-forward control using intrinsic signals, the DBS system is placed in parallel to intrinsic neural circuits. Therefore, this whole system may be regarded as hybrid neural circuit. I believe this direction may be one of many important developments of DBS which will happen in future in this field. Thank you for your attention. 감사합니다.
Thank you very much for your interesting lecture. It is time to discussion. Any question or comment? Professor John, do you have any question, comment? 전 선생님.
I'm Dr. John, a neurologist who will be working with Professor Peck on functional neurosurgery. I understand that neurosurgeons in Japan are overloaded with adjusting the parameters of DBS, and I heard the same comment by the prominent neurologist in the United States having the same problem. And I think we should share the responsibility of caring for the patients together. and I understand that you'll be very busy. Your surgeons will be very busy doing this surgery, and I think that neurologists in general are better positioned to have more time and to control medication and the DBS parameters. And I have a brief question to you. I see that you have a lot of interesting patients who were operated like post-stroke tremors and post-diagnostic the patients. And in general, I thought that patients with structural damage are unlikely to respond to functional surgeries. And I want to hear what the responses were to your surgery.
I used to think that the structural damage is a disadvantage for DBS therapy, but from my experience for last 15 years, you don't necessarily think that the structural damage is disadvantage. For example, post-stroke choreoathetotic movement is sometimes very well controlled by DBS, something like hemibalism or hemichorea, or sometimes the cerebellar posterior tremor. As you pointed out, it is really difficult to control, but it is sometimes very successful, so you should try.
Microphone.
Very often, patients will, when a thalamic stimulator is first turned on, patients will experience some discomfort. Very often, when a thalamic stimulator is first turned on, patients will experience some discomfort, paresthesias, which typically abate in 1 or 2 seconds due to activation probably of the VC. With your feet forward, are the patients not experiencing a number of those uncomfortable episodes each day every time they go to use the extremity, as opposed to simply having the device on at all times and therefore only experiencing it in the morning when they turn the device on?
That's a very important point. We become to experience less number of patients who complain the sensory experience at on, because we decided to move the electrode a little bit anterior from the VC nucleus. The reason that many patients used to complain the sensory experience early 1990s, that we thought that the target of DBS is the same as thalamotomy. So we went very close to the VC nucleus, but we don't need to cross to VC nucleus for DBS system. So to my experience, these several years, I don't experience such a patient now.
Professor Katayama, thank you for your informative and useful presentation. I have 3 questions. First one is that the parameter of motor cortex stimulation to decrease the involuntary movement using, as you mentioned, the feed-forward control system is the same for pain control in the post-stroke patient?
Yeah, that's very important point, which I decided to exclude from my talk because of time is limited. The parameter of motor cortex stimulation is very different from what we are using for DBS. It's approximately 50 hertz as a frequency, and the stimulation intensity should be below the motor contraction threshold. And it's obviously same as DBS, but we need to stimulate the area where you can provoke muscle contraction when you increase the intensity. But therapeutic stimulation is performed at subthreshold level.
Yes, thank you. The second one is that have you done microelectrode recording of the deep nuclei during the motor cortex stimulation?
Oh, I do not do micro recording for motor cortex stimulation because we stimulate motor cortex epidurally. We don't get into the brain tissue
Thank
for
you.
that surgery.
And the last one is that, do you have any experience of motor cortex stimulation for the patient with focal motor seizure patient?
If the patient have a focal motor seizure, we consider such a patient contraindicated.
Thank you.
Do you stimulate motor cortex for therapy of focal epilepsy?
No.
Any question? No? I have one question. Professor, nowadays, what is the role of destructive surgery, for example, thalamotomy, paridotomy, is totally abandoned or not?
I have not abandoned personally the thalamotomy because thalamotomy have some advantage against DBS because you don't need to implant a device, and when I need to treat the young ladies, I don't want to put anything to that young body, so I place the microthalamotomy to treat intention tremor or writer's cramp, something like that. But I have not doing palidotomy anymore for the last 8 years. So the thalamotomy is still.
So only
option.
the indication for thalamotomy is for young lady.
Young people who doesn't want have a device within their body.
Okay. Any question or comment? 마이크를 안 들립니다.
As far as I know, you have a tendency to increase in deep brain stimulation for controllable tremor and epilepsy, vagal stimulations. But the problem, as I know, is very expensive. And how about in your country, is it covered, and how much it costs? Could you tell me?
Since the year of 2000, the stimulation system is all covered by government-supported insurance, just for pain and movement disorders. The epilepsy and depression cannot be treated by insurance. And dystonia is question. We include dystonia to involuntary movement like Parkinson's disease. That is a description of our government insurance book. So dystonia are now treated by insurance.
Professor Beck, can you explain about the situation of insurance coverage in Korea now for DBS operation?
Yes, the government just have allowed to support the doing the DBS surgery for the patient with Parkinson's disease and essential tremor. So they cover the 80% of the price of the DBS from the January of this year. So we can give some help for the many patients with the Parkinson's disease. Yes.
Thank you.
Any question or comment? Please. 마이크 좀.
Mr. Kaneyama, very nice talk. Question: have you looked at your recordings of tremor, your micro recordings in VOP and VIM, and correlated that to whether they occur before the activity in the muscle or after the activity in the muscle. I ask that because it may be easy, if it occurs before, to use that as part of your internal feed-forward mechanism.
The coherence before activating the, for example, deltoid muscle, or after activating the deltoid muscle are different. The coherence becomes different. So that difference can be used as a trigger signal of controlling the system. So I feel your comment is very nice for future development. I need to consider more details. Thank you.
더 뭐 질문이나 코멘트 없어요? Okay, thank you very much, Professor
Thank you.
Katayama. Thank you very much. Now, Professor Chung, the chairman of our department, present you a letter of appreciation.
Professor Yoichi Katayama, Professor and Chairman, Department of Neurological Surgery, Nihon University School of Medicine. On behalf of the Department of Neurosurgery, Seoul National University College of Medicine, I take a great pleasure in presenting you this letter of appreciation on March 19, 2005 at the Symposium Neurosurgery Update 2005. Hyewon Jung, Professor and Chairman.
Now we move second lecture. Second lecture will be presented by Dr. Altman from States. 이 알트만 선생님은 미국의 뉴욕에 있는 마운트사이나에 지금 부교수로 근무하고 계신데 아직 좀 젊으신 분이긴 하지만 아주 그 젊었을 때부터 활동을 활발히 하셔가지고 런던 때부터 여러 가지 그 상도 많이 받으시고 또 여러 가지 아너럴 소사이어티의 멤버십도 많이 가지고 계신 그런 훌륭하신 분입니다. 그래서 이번에 오시게 됐고 또 여기 오셔가지고 우리 백 교수랑 같이 또 라이브 서저리도 같이 하기로 예정이 되어 있는 분입니다. 토픽은 마찬가지로 그 DBS에 대해서 그 말씀을 해주시겠습니다. Dr. Aston, please.
Good afternoon. I want to thank Dr. Pak, Dr. Kim, and Dr. Jung for having me here. It's really a great honor and an honor to be here on the occasion of the opening of the new Movement Disorder Center upstairs. I went up to see it before coming down here. Very impressive. I've been given the daunting task of trying to provide an overview of movement disorder surgery, or at least deep brain stimulation. And the field is becoming so vast, it's very hard to really cover it adequately. But I'm going to try. New Yorkers, people from New York speak very quickly, so we'll see what we can do. For those who don't know, Dr. Schills, who's here with me, and I practiced for the last 7 years at Beth Israel Medical Center in New York, and recently I moved on to Mount Sinai, and Dr. Schills up to the Leahy Clinic in Boston. And at the outset, I want to acknowledge all of the people that have worked with us over the years to help generate the kinds of results that I'm going to be showing today. But down here in this picture is really the core group that was most responsible. It's myself, Dr. Schills, Michele Tagliate, an excellent movement disorder neurologist who works with us, and Joan Miravite, our nurse practitioner. But as you can see, it's a true team effort. We now have, in Dr. Katayama's lecture, a new explanation or another reason that DBS is better than ablation. There are many reasons why we've moved from doing this to this, and they're really highlighted here in these side-by-side pictures where you see one, a large lesion placed in the globus pallidus of what obviously was already a sick brain. It's unilateral, it's relatively large, and it's destructive. And on the other side, we see a bilateral procedure to treat what are very often bilateral disorders, much less destructive, and therefore, in my mind, better, even, and in my mind, even for younger people. So the advantages of deep brain stimulation: it's reversible, unlike a lesion. Bilateral procedures are far safer. It does not preclude future therapies. A major advantage, as I will show you, at least in the dystonia group. But things we do have to worry about: infection with implanting a device, long-term maintenance of an implanted device. We are still dealing with a symptomatic therapy. This is not a cure for any of these movement disorders as far as we can tell, and we still don't understand the mechanisms of action. What I'll try to discuss today, at least in part, each of these things: the importance of proper patient selection, proper anatomical targeting, physiological targeting, and deal with some of the controversies there, clinical results, some controversy about the DBS mechanism of action, at least in Parkinson's disease, and then a little bit of at least I'll touch on where I think the field is going in terms of future developments. Obviously something like the types of things that Dr. Katayama were discussing, feed-forward, feedback mechanisms for activating DBS, very important. And then competing technologies. What are the types of things that are out there that might actually supplant DBS as the first line of surgical treatment for movement disorders? Patient selection, really the key. Right now, in the general indications for using surgery, at least in our hands, a diagnosis, a true diagnosis of Parkinson's disease and not a Parkinsonian syndrome, essential tremor or primary dystonia within the movement disorder group. Patient must have disabling symptoms. It's not enough that they simply have a tremor, but the tremor really needs to be disabling. They've had an inadequate medication response, and that defining inadequate can vary from patient to patient and doctor to doctor. The patient should still be cognitively intact, most important in the Parkinson's group, and the patient obviously needs to be medically able to undergo surgery. Preoperative evaluation, again, team approach, and involves all of these people. A good movement disorder neurologist is absolutely invaluable, and I was very happy to see the great partnership that's developing here. A good stereotactic neurosurgeon, neuropsychology, neuropsychiatry, MRI, PET, and of course a good internist. The importance of PET, I believe, has been amply publicized in that we can distinguish very definitively in patients where there is a question between true Parkinson's disease, where the lentiform nucleus is hyperactive on FDG PET, as opposed to PSP, where the lentiform nucleus and the thalamus are hypoactive. And that is a test with great both sensitivity and specificity. When I was at NYU, we used it on all of the cases. Now we use it in select cases where there are certain clinical red flags which would indicate that the patient may not have true Parkinson's disease. Why is that important? On 2 occasions anyway, we purposely, not by mistake, purposely did operate on patients with multisystem atrophy and showed that while there was some modest improvement at 6 months, that by 18 months postoperatively, one patient was already getting worse again, the other patient was beginning to worsen, and that in the end, only the symptoms that were levodopa responsive responded to DBS, as is the case in Parkinson's disease, and gait was never improved. So that while you might get some modest improvements in these patients, by and large, their physiology is not amenable, at least to subthalamic DBS, and probably should not be performed. The currently accepted indications in the United States for DBS for movement disorders, so these are specifics: the ventrolateral thalamus, which Dr. Katayama just covered very nicely. Again, best for essential tremor. The rare patient with true tremor-predominant Parkinson's disease, at this stage, When someone comes to me and they have tremor predominance, I would at this time operate in the subthalamus and not in the thalamus, because I know that over time they will progress, and that the thalamus, in my hands anyway, does not adequately control the other symptoms of Parkinson's disease that typically are more disabling, that being the akinesia, dyskinesias, and rigidity. And then again, select patients with intention tremor, mostly due to multiple sclerosis, or as you saw, post-stroke. Although honestly, that last indication is not approved in the United States. I have to give that disclaimer. Okay. The globus pallidus I use exclusively for dystonia. I have been unimpressed with the results of pallidal stimulation for Parkinson's disease, and I've only done it on a few cases because of that, and so I won't touch on that. There is a large multi-center trial in the United States, which hopefully will be coming to completion in the near future, comparing in a randomized, prospective, blinded fashion bilateral globus pallidus to bilateral subthalamic DBS, and we'll have a more definitive answer in terms of the comparability of the results between those two targets. But for today, we'll discuss globus pallidus exclusively for dystonia, although you can expect to control your dyskinesias very well at that target. But primary torsion dystonia is really, in my mind, the best use today of globus pallidus stimulation. For Parkinson's disease, we treat exclusively now at the subthalamus, and the indications for subthalamic DBS, rigidity, tremor, freezing spells, akinesia, levodopa-induced dyskinesias, gait abnormalities, and there's a question. I know Dr. Bowman's son, a good friend of mine, is speaking at another conference here today, has done a fair amount of work looking at the subthalamus as a target for dystonia with some very interesting results. So the question is out there now as to which of the two sites might be the better target for dystonia. Current surgical technique, in most people's hands, although it's changing and rapidly evolving, involves a patient being awake and off medications when possible. The operation is still done for the most part with a stereotactic frame. You see the Lexel frame, which is the frame I use here. All through these, stereotactic MRI, with or without CT fusion. There are a number of different ways of doing that. We'll talk about that briefly. Microelectrode recording, at least in my hands, although there's controversy about that, and I'll address that controversy. And then the stimulation and the pulse generator being implanted. So today, we're still looking at a frame-based surgery, although there are two very good frameless technologies that are being developed, which will, I think, become mainstream in the next few years. Anatomical targeting, I prefer to use fast spin echo inversion recovery MRI, as you see here. The reason I use it is that the physics of that pulse sequence are most resistant to magnetic susceptibility artifact. And magnetic susceptibility artifact will tend to shift your fiducials. And so fast spin echo inversion recovery not only gives these beautiful anatomical images of the brain, but prevents shift of these fiducials from which we determine the coordinates. I tend to use an indirect targeting based on the position and the coordinates of the anterior and posterior commissures. So I determine directly the coordinates for the commissures, take the mean of those coordinates to get the coordinates for the mid-commissural point, and then determine my coordinates for my target based on that. Okay? There are others who perform direct targeting, for instance here on a T2 weighted image showing the subthalamic nucleus. And that will allow you to look at the target directly. In the globus pallidus, I will use coronal inversion recovery as well to look for the optic tract, which anchors my laterality and anchors me in the AP direction as well. The reason that we do not do that is based on a phantom model and also clinical experience where, and there have also been a number of papers now published, which show that the Lexel frame at least, and other frames as well, are inherently less accurate in their targeting in the coronal plane. They were designed primarily in the CT era for targeting in the axial plane and then were adapted to MRI. So, while you may be able to see the STN, the coordinates you derive for the subthalamic nucleus based on coronal images are inherently, on average, less accurate than the coordinates you'll derive based on the indirect targeting method. This is from a phantom study that Dr. Shills and I conducted, where we looked at targeting of, in a phantom compared to the actual known coordinates for each of those targets using these various pulse sequences both in coronal and axial plane. And as you can see, in the coronal plane you are inherently less accurate, whereas whether you're using inversion recovery, T1 weighted, or SPGR, T2 axial, and CT, much more accurate. Our work's been confirmed. This is from Sonnenschein et al., Neurosurgery in 2000, looking at the NYU experience. And here they talked about MRI is direct targeting on coronal images of the STN. Atlas was using a digitized stereotactic atlas that could be form-fit to determine the coordinates. And then MCP is this mid-commissural point technique that I just described. And what you see, especially if you look combined, is that direct targeting on MRI was their least accurate method of determining the final coordinates for the target as determined by microelectrode recording. So again, confirming the idea that while you can at times get very beautiful images on T2-weighted coronal MRI to see the subthalamic nucleus, the coordinates you will derive for that target are less accurate than what you can calculate indirectly. Looking at targeting workstations, they are very handy. They increase your targeting capabilities. They eliminate human math errors. Both the target and the entry point can be chosen so that you can optimize your trajectory. You heard from Dr. Katayama the importance of not only selecting the right target point, but selecting the right trajectory to that target. I'll touch on that a little bit with our experience in the subthalamus. Digitized stereotactic atlases are available, although as I just showed, I'm not sure how useful they are at the moment. And then image fusion is very important, that you can fuse your MRI to CT. You can fuse different types of MR images so that you can take advantage of different types of imaging within stereotactic space to get the best possible anatomical target before you begin your surgery. Nevertheless, we still need physiologic confirmation of our target. And as we all know, single-cell microelectrode recording is the highest resolution technique for determining where you are. There are many fine surgeons in the United States, Europe, elsewhere in the world who can do these operations. My good friend Marwan Hariz is one example, without microelectrode recording, based purely on macroelectrode stimulation and impedance monitoring. I prefer to have the comfort and the high resolution that microelectrode recording provides. It takes a little more care. You need to have a very good physiologist very often to work with you. But in the end, I have much greater confidence of where I am on a case-to-case basis for performing these surgeries. This is my idealized trajectory and placement for a subthalamic nucleus stimulator. I tend to be about 65 to 70 degrees to the intercommissural plane, and the reason we'll talk about why, but I believe it is very important not only to be within the subthalamic nucleus at about 12 millimeters lateral, this is from the Schulten-Brand-Warren Atlas, but that you need to pass through this region of the zona incerta and Ferrell's field H2 in order to get your best results. I'll show you data later when we talk about mechanism where we find that 80% of the time the electrodes we use for therapy are these that are located at the dorsal border of the STN and just above the STN in the region of the zona incerta H2. If you take a more anterior trajectory, you will come through STN and perhaps even come through a larger stretch or span of STN than I do, but you will miss what I think is a critical component of the therapeutic response, which is Ferrell's field H2. And so again, trajectory matters, not just target point. Many have seen this, an example of kinesthetic activity. The way we use microelectrode recording is that we want to confirm that we are both in the subthalamic nucleus, and if it plays, So what you see here is with wrist extension, the change in firing rate of this cell. Similar effects are seen in the motor subregion and the globus pallidus. So very important to understand that not only that you're in the proper nucleus, but that you're in the motor subregion. This is now the same patient, but with active movement. These recordings, as we'll show in the operating room in a couple of days, we can then take these recordings and map them against the Schaltenbrand-Warren Atlas, a technique that was originally developed with the Emory Group, mastered by Dr. Schills. And with that, we can be very confident about where we are. In this case, in the first trajectory, we felt that we were slightly anterior. We moved 2 millimeters back, performed a parallel trajectory, found a greater span of STN, more kinesthetic activity, and therefore would have implanted along the STN, along the second trajectory. Sedation. There was a recent paper from Professor Agid's group in Paris showing that their results were not as good when they performed surgery with microelectrode recording on patients who required propofol, sedation with propofol. And just as a note, we have had great success with dexmedetomidine, which is a selective alpha-2 agonist. And just as examples showing the difference, this is one patient we operated one side with dexmedetomidine, the second side on propofol, and you can see the difference in the signal-to-noise ratios. So DEX allows us to perform these operations in patients in a conscious sedated state and still get very good signal-to-noise ratio on our microelectrode recordings. And this is not so important in the Parkinson's group. Similarly here now in a dystonia patient. For dystonia, this is critical. Because you're dealing very often with children and adolescents who simply cannot undergo or won't tolerate an operation while they're fully awake, and we've had great success doing dystonia surgery with DEX. In terms of the importance or the impact of microelectrode recording on final target placement, that's always been one of the arguments against microelectrode recording, is that it's a research tool and it doesn't really impact your targeting. Very similar to a paper I had published previously on in neurosurgery on pallidotomy and microelectrode targeting. We looked at the impact of MER on targeting the subthalamic nucleus. 75 patients, 152 implanted electrodes in this 4-year period. It was a total of 288 recording trajectories, a median of 2 per patient with a range of 1 to 5, although all of the 5s were early in our experience when we were first beginning to do the surgery. And you see our hemorrhage rate, which is exactly the same hemorrhage rate as you will see for surgeons who do not use microelectrode recording. So we demonstrate that microelectrode recording can be done safely without increasing the risk of hemorrhage, which again has been a major argument against the use of microelectrode recording. When we look at the number of trajectories required to localize our target, this is what's called a Pareto analysis. So you go from the most frequent to the least frequent. So, and this is cumulative percentage. So what you can see is that better than 70% of our cases are completed either with just one recording trajectory, which confirms that we're in the right place, or with a second recording, and that more than 80% of the cases are completed with no more than 3 recording trajectories. As you will hear from others, the French, for instance, will use 5 recording trajectories on each side routinely. I think that that is not necessary. I think that to do the recordings one at a time, you reduce the number of trajectories through the brain and reduce the risk of the operation, especially that of postoperative confusion. These were the targeting adjustments we needed to make, and what's most important is that Z was the least accurate, but that's related to the fact that the axial images I'm using for determining our coordinates are 3 millimeters thick, and therefore I have a plus minus of 3 millimeters in my Z-axis. But the balance of that is that microelectrode recording can define the borders of all of these target nuclei within tenths of millimeters. So that's where it's most accurate. Microelectrode recording is most accurate where my anatomical targeting is least accurate, and so, if you will, a yin and yang there where the two complement each other. looking at the three-dimensional targeting adjustments. So this is total change in the target based on microelectrode according from the original anatomically chosen target in millimeters. The most frequent occurrence is about a 3 millimeter change, 2 and 1. So, where are we? We're at almost 80% of the cases. The change, the three-dimensional change in the target is 3 millimeters or less. But in slightly more than 20% of the cases, it's more than 3 millimeters. Looking at computational models, especially the work of McIntyre and Grill, it seems that any one contact has a radius of influence. The current that's being generated will influence tissue by about a 3 millimeter radius. So I would consider a move of greater than 3 millimeters in my target of potentially importance, of clinically significant importance, clinical significance, sorry. I'm trying to speak too quickly. Anyway, so that would say that in about 20% of the time, microelectrode according will lead you to make an adjustment in your targeting that should have an important or a major impact on your final outcome. Now again, circumstantial evidence, but I think strong circumstantial evidence that microelectrode according is important for performing these surgeries consistently well. Once we're happy with our microelectrode according, we then test stimulate with the DBS electrode. The 3389 electrode, which is shown down here, was designed by Dr. Benabid specifically for the subthalamus. However, I tend to use the 338, I always use the 3387 regardless of target. Again, because of the 3 millimeter radius, decreasing the spacing from 1.5 millimeters to 0.5 millimeter, I don't think is going to have any difference. And the trade-off is that you lose volume that you can treat. And again, you may not always use the same contact every time, and therefore the greater area that you can cover, you're probably better off. We won't go through the microelectrode. The importance of fluoroscopy to make sure that the electrode has indeed traveled straight to the target and does not move while it's being locked down. And the importance of performing MRI to make sure that there's been no hemorrhage. Okay, I will skip through tremor since Dr. Katayama has covered that nicely, and he has far more experience with that than I do. Okay, Parkinson's disease. We're in the process of going through all of our data in a more detailed fashion and with longer term, but the last time we looked, and this is in, this was at 48 patients at 3 months, 21 at 1 year. Again, as others have reported, this is looking at the UPDRS, the Unified Parkinson's Disease Rating Scale, motor subscore, off medications and on medications. So this is before the operation, off and on, again demonstrating that the patient is still levodopa responsive, and then 3 months and 1 year out, off and on medications. This is now off medications, but with stimulation on. And as others have reported, the most dramatic impact is in the off state, and that the off state begins to approximate the on state, so that the classic patient in Parkinson's disease who is fluctuating between off and on is fluctuating between these two states during the day, and very erratically, I might add. Now the fluctuations are far reduced because of the off state improvement. Same was demonstrated by Obeso. And moving on to activities of daily living. So this is now the ADL subscore. And what we do see here is that while from a motor standpoint, that being examining the patient, you may not see a significant difference from off to on, that for the patients, there is a functional improvement in their ability to perform their activities of daily living between their off and on state. And that probably has to do with reduction in dyskinesias, okay? Which only accounts for a few points on the total UPDRS motor subscore, but it is dramatically impacts a patient's ability to actually do things, and is also impacted greatly in the subscore number 4. Again, Dr. Obeso, very similar results, also showing a modest on-state response as well as the off-state response. Pictures always speak louder than words. So this is a classic patient treated with bilateral subthalamic DBS. She was in her, say, 54 at the time of surgery. She had had Parkinson's disease for 9 or 10 years. This is her preoperatively in the off state. Classic Parkinsonian tremor, severely bradykinetic. Classic stooped posture and slow gait, festinating gait. So now again, this is preoperatively, and this is now with medications on, and immediately you see the dyskinesias induced by the medication. However, she's now quite responsive. So it's not that she's no longer responding to the medication, it's that she responds for very brief periods of time and very erratically. So she told us that this would only last for about 30 minutes at a time for each dose, yet she was taking her medications every 3 hours. So for the most part, she was spending her time in the off state. And you could see she was able to walk quite nicely. This is an ideal patient for subthalamic deep brain stimulation. And in fact, a patient that has done extremely well with the surgery, as you'll see in a minute. So now this is 3 months after surgery, off medications, stimulation on, and you can see that her performance now is more as it was preoperatively in the on state. Her face is more animated. She can perform her tasks more fluidly, and then you'll see her walking. This woman is now 4 years out from surgery and has maintained this result. One thing I'd like to point out, an issue that has been raised, is whether or not the effects on dyskinesia are related to medication reductions we'll move on. What I want to leave with Parkinson's disease is probably this slide from Obeso's work, which I think really highlights exactly what the operation does for the patient. What matters to the patient is this. At baseline, red is off. So this is spending, the medication is either not working or they've taken it and they've shut off. Green is on, a good on state. For instance, that woman for that 30-minute period preoperatively. And then green here is on with dyskinesias. I'm sorry, this is on and this is on with dyskinesias. And when you look 6 months after the surgery, whereas they were spending 75% of their day in a bad state, either off or on with dyskinesias, they're now spending 75% of their day in a good on state. Their dyskinesias, their off states are markedly reduced to only about 15% of their day, as opposed to 50% of their day, and on with dyskinesias reduced to 10% of the day. And for patients, that is the take-home message. You can talk about 40%, 60% improvements in the UPDRS, but what they understand is that rather than spending only a quarter of their day in a good on state, they're now going to spend 3/4 of their day in a good on state on average. And I think that's really the take-home message of what this operation can do for Parkinson's patients. Moving on, I think we have a very large experience now. We're one of the largest in the United States of treating torsion dystonia. We'll move through this because most of this is in the handout. Our experience, it's now up to 25 patients, but the last time we looked at the data, 22 patients with medically intractable dystonia, 13 male, 9 female, 18 with primary dystonia, 13 of whom are DYT1 positive for the DYT1 defect. But 3 of these had been treated, I'm sorry, it should be 12 DYT1 positive, and 3 had been previously treated with multiple thalamotomies. Median age, symptom duration. Okay. Looking at the improvements, and this is now the Birk-Von-Marsden Dystonia Rating Scale at 6 months and 12 months. When we look at primary dystonia, we see an improvement of 56%, but that's all comers. The DYT1 negatives at 6 months and a 61% improvement at 12 months. DYT1 positive seems to be doing not quite as well, but if we take out the 3 patients who had had previous thalamotomies when they were young, we see that DYT1 with no prior surgery has the best, or almost a 75% improvement in their Birk-Von-Marsden about a year after surgery. Secondary dystonias, as other people have reported, don't do quite as well. We also know, as others have now reported, that it takes anywhere from 12 to 24 months until we see the full impact of palatal DBS on the dystonia patient. One of the potential advantages, at least in Dr. Bowman's son's hands, of the subthalamic nucleus is that they get there faster. Same is true of the disability subscore of the Birk-Von-Marsden. Now, when we look at the patients who are DYT1 positive with no prior surgery, we see that the improvements are seen in all of the patients over time. Yet the patients that had had previous thalamotomy got improved more modestly, but after 6 months to 12 months, flat. And this is continued, flat beyond. Dr. Koob's very similar. Again, seemed to find that the DYT1 patients fared the best, with improvements, at least in his hands, of 83% 2 years after surgery. Again, improvement progressive over the first 1 to 2 years. And in Dr. Koob's hands at Montpellier, children responded better than adults. From the recent French multi-center trial published in the New England Journal, 22 patients between the 3 centers. They performed a blinded comparison of off versus on stimulation at each time point, and a superior response was seen in patients with phasic movements rather than tonic postures. They found the DYT1 status was not predictive of response. These are out complications in the dystonia group. And again, a video just to show you. This is a young lady. This was our very first dystonia patient. She's DYT1 positive. This video was taken about, you can see the poor control of her hands. You'll see her try to walk in a minute. She really can't. She cannot hold herself up on her feet. This is 6 months before her surgery. We operated on her emergently because she was in a dystonic crisis and had been maintained in an Ativan-induced coma for 3 weeks prior to the surgery. This is now just 1 month after her surgery. Beginning to gain control of her fingers, able to move her feet a little bit better, but you can see still not able to support her weight. 6 months after surgery. Full control of her hands. But again, and you see this left foot in particular. At this point, we had an orthopedist perform an examination under anesthesia, and we determined that this was no longer neurologic but orthopedic. And this is now 18 months after surgery and 6 months after having a heel cord lengthening procedure. And you'll see her full ability to walk. And she is now 4 years out from surgery maintaining this result. I see I've run out of time, so we'll close with, go through mechanism of action. So let me just talk about where I think we're going. I've now, I think, adequately shown you where I think we are. The future will be new targets and new indications for DBS. For sure, better implants. You saw with Dr. Katayama's beautiful presentation, the possibility of developing closed-loop systems, smart systems that respond to specific parameters, much like an on-demand cardiac pacemaker. Miniaturization certainly will happen, so these implants will become smaller and easier to implant with fewer complications. We will get longer-lived and rechargeable batteries. And better surgery, frameless techniques, and cortical stimulation may very well hold some promise, and I think Dr. Shills will be discussing that later in the week. Alternative technologies, brain infusions, stem cells, gene therapy. We also have to keep an eye on those things because they may in fact prove curative rather than symptomatic treatments. Thank you.
Yes, thank you very much. Any question or comment? Professor Katayama.
Thank you very much for your excellent lecture. I enjoyed your talk very much. I agree that using the longer DBS lead for STN stimulation, I have had the same opinion for many years to stimulate, as you have mentioned today. That option to stimulate the suprasalamic area is very important for the patient benefit, maximized. But you approached the STN about 60 degree. I approached the STN at 45 degree. Which is better? I would like to your opinion.
Obviously, I have a bias that I think that if you look at the atlas, and I guess I can go back and bring that slide up, that in order to span 4 millimeters or more, typically you want 4 or 5 millimeters of STN. Oh, it's not up there anymore. Okay. The Farrell's field H2 is a very small area, and it sits just on the dorsal border of the STN at 12, 13 millimeters lateral as it's traveling from the globus pallidus to the motor thalamus from lateral to medial. In order to have an effect in that region, and I think that that's very important because the entire outflow of the lenticular fasciculus, the motor outflow from globus pallidus to thalamus, is passing through that area in a very discrete way. And I think that that is the key to the response. And I think that at a 45-degree angle, you will come in too low, and you may miss it. If you're coming through the subthalamic nucleus at that 45-degree angle, you will be pitched too far anterior, and you will miss it. In order to go through it on your way to the subthalamic nucleus, I believe you need to be at 60 to 70 degrees. And so my personal bias is that, from our experience, is that we've had our best results when we are at 65 degrees or so, 60 to 70, somewhere in that range. You must not record the thalamus when you come down. Do you record in the? No, yeah. If we don't record the thalamus, I'm always concerned that we're too far forward. So we have a nice recording of the thalamus, then the subthalamic white matter, ZI and H2, and then the STN. and then the Niagara at the bottom. So it really also gives us, the more borders you have, the easier it is to map your recordings against the atlases. If you have just the STN, then again, you don't know where you are in terms of your angle, your trajectory. So that's,
I guess you are aiming the middle of the bottom of STN, so you can get through that area you are pointing.
correct. That is where I'm aiming, but that's not the electrode that we end up using. That's sort of my signpost.
Yeah.
Right, but we won't use the zero contact. We'll tend to use 1 and 2, which are dorsal in the nucleus and just above the nucleus.
One more question, may
Yes,
I?
yes, please.
Reading your paper in this abstract book, I want to just confirm whether you think that a drug-induced hallucination is a contraindication of STN stimulation?
It's not an absolute indication. I think what I said is we like the patients to be hallucination-free for 30 days before the surgery. I think that if you operate on the patient while they are still having those hallucinations, you increase your risk of postoperative confusion. We would rather reduce the medications and have the patient have a clearer sensorium when they have their surgery. We think that that reduces the risk of the complications. So it's not that it's an absolute contraindication, just I don't like the idea of them actively having hallucinations when we do the surgery.
When we do the surgery, we can reduce medication so the hallucination can be solved. That is the other thinking. Thank you very much.
Thank you.
Any other question, comment? Professor John, what do you think about the topic about the DBS including force field age, Dr. Altman's idea, neurological theoretical basis? Do you agree with Dr. Altman's idea? He said that he include the electrode, the subthalamic nucleus as well as the force field age.